So I'm going to cover a little bit the bladder and the bowel management, and the two have some commonality. So I wanted to start a little. Actually, here there are too many of these. He already talked, Tom already spoke about the anatomy some. This is just a summary to say basically we have multiple levels going all the way from the brain down to the bottom of your spinal cord. And there are, for instance, for bladder, there are about 5 centers that control it. Of course, you guys are the Cadillac of the neurodegenerative disorder from our standpoint. That's why you are called multiple system atrophy, and you hit at multiple levels. So depending upon which level, you may present with one symptoms more prevalent or another, but at the end, the entire system will degenerate, and so the control both of bladder and bowel is lost. This is just, again, another summary to, again, indicating that the system controls every autonomic domain. We'll focus on the bladder and bladder at this point. Now, both systems are affected, are involved in controlling pretty much all your autonomic function. And in some systems, there is only one that's involved. For instance, for sweating, it's just a sympathetic system. But you see that in all the others, they both have a role. And sometimes they work in synergy, so they work together. For instance, for sexual organ, they both have to work together, although in sequence. And for other organs, one does one thing and the other does the opposite to balance the situation. And that's one thing that's lost here is like you have an orchestra and the players are not playing together. And that's what happened with MSA and the control of bladder and bowel. Now, let's start with the bowel. Now, before you go to the bowel, something has to go through your mouth. And another common problem that most of you end up in having at some point is the issue of the swallowing. And this is an issue that allows you to have, impact the ability to handle secretion, drink, eat, and swallow medications. Common symptoms that people may have include the drooling, difficulty chewing, prolonged chewing, etc. We generally have folks go through an evaluation with a therapist, and depending upon which stage you are in, the therapist can teach you some strategies. Some are dietary modification, some are simple tricks, and then when things are really, really rough, then you end up in requiring a feeding tube. Again, there are some tricks that some of you have, I'm sure, have heard from a therapist, how to handle pills, particularly, which pill seems to be an absolute nightmare for people with swallowing difficulty, and then adjusting food type and food softness, preparation, etc. And then again, when things are really problematic, we go to a feeding tube. Keeping in mind, when people hear the word feeding tube, they said, oh my gosh, I can't eat anymore. No, 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 no. The feeding tube will allow you to have adequate oral intake, caloric intake. You can still then save the effort of chewing for the things that really, really you enjoy from a taste standpoint. You don't want to put the chocolate in a feeding tube, okay? All right. So again, does not prevent a person from continuing to eat the ice cream, the chocolate, whatever, okay? Just be careful. Let's go towards the issue of the gut. Now, the stomach and the small bowel usually are not terribly impacted in MSA, surprisingly enough. They are impacted in other conditions, but not so much in multiple system atrophy. The lower GI, so the gut, is really what play the role of the star here. And these are slides, by the way, that are courtesy of my gastroenterology colleagues that does motility. And they consider themselves the lower brain, okay? The GI tract actually has pretty much a brain on their own. That's the enteric nervous system, and is quite complex and does a whole lot of things. And yes, it's under the control from the IR system, but they have almost like a pacemaker intrinsic to itself. And that's what is lost in any autonomic disorder, and specifically, again, there are certain aspects that we'll talk about that are more classic for Parkinson and multiple system atrophy. So the players here are the colon, which is really, it's a big volume capacity system that mixes the food. And the main role, actually, of the colon is to reabsorb water. About 10% of what comes through the colon in a typical day is then excreted. So the colon absorbs 90% of what comes through, which is mainly water at that point, the absorption part. Then the other component that's critical here is the sigma and the rectum, which is really the volitional reservoir. When the stool reaches that level, then it's really the signal is, I have to go. Now, sometimes that signal is not perceived by the brain if there has been neurodegeneration. And that's where you may have fecal incontinence, because you didn't feel that your rectum was full. Other times, the rectum is full, you have to go, and you just cannot get it out. The bowel, as I said, has its own sort of pacemaker system, which are actually the cells of Cajal. And this is a good example of what the propagation of the wave that basically pushes the food first, and what then becomes stools as they progress through the system. So people sometimes say, why can't we do a pacemaker for the gut as we do for the heart? Well, the heart, all you need is one signal, boom, and then the heart knows what to do. Here you will need a pacemaker pretty much every inch. And they have to work, sequentially, so very, very hard to do. But that's what's supposed to happen in a normal functioning system. The other thing that's very important that gets malfunctioning in conditions like multiple system atrophy, but can happen separately, is the pelvic floor function. Now, the pelvic floor, which is really, this is a very schematic image here. Again, the different muscles need to work in synergy. So when you want to go, you need to have certain muscle contract, and you want the sphincter to relax. Well, in conditions like multiple system atrophy, the motor component too, the coordination is lost. And that signal, one pushes and the other one tighten up. Oh, no, it doesn't work this way. And so that's where it's a big problem. And we have patients that have just pelvic floor dysfunction due to incoordination. And those can be retrained with certain physical therapy exercise. Early, sometimes people with multiple system atrophy will respond to therapy, but because it's the signal above that's altered, then sometimes the therapy really doesn't work, unfortunately, very well. Let's talk about these cells that are crucial in controlling the system. If you look at, you count these cells that are the pacemaker cells that basically are the engine of the gut. In control patient and in patient with Parkinson's disease, and the same applies to you, the number drops dramatically. And probably you can see it here. See it on the left will be the number of cells that you should have, and on the right you see it's a really a major dropout in patient with Parkinson's disease. Now, constipation is not unique to you guys. Constipation is a very common problem. It can happen in a variety of conditions, and it's very common in people that are very inactive, becomes more common also in the elderly. But depending upon if we know that the system is intact, or if we know if there has been a damage and dropout of nerve cells, the treatment is different. What this basically says is if you have, for instance, a disorder of defecation, which is a pure, unique incoordination of the pelvic floor, drugs don't work. What works is the retraining. If you have an intact system, but it's just a slow transit, things like fibers work well. If you have a system like yours, fibers alone usually don't work. So we need to use different drugs. How many drugs work? Well, some drugs have been proven to be effective. And one classic is bisacodyl. There are a lot of other drugs available, and there has been a lot of studies showing this. Some of these are commercially available, some are still in development, and others are used only in a selective sector population. But the point is, there are a lot of drugs available. Talk to your doctor about what option might work best for you. Start with the simplest and increase as necessary. Keeping in mind that if some of these drugs are very powerful, so you have the risk that you go then from constipation to diarrhea. So it's going to be really a very fine balancing act. And every drug, unfortunately, has side effects. So nausea is also a bigger component for side effects from these drugs. So keep that in mind. Now, let's talk a second about fecal incontinence. When that happens, usually it's because there is a loss of tone in the pelvic floor, a loss of tone of the sphincter. And that could be also in combination with the fact that sometimes the sensation of a fullness on the rectum is lost. So that becomes really, really problematic. So the best thing is to work on a very tight schedule with bowel emptying. Also, if you have a lot of problem with constipation and you don't go for a whole week, chances are in the bowel things will start to ferment. And when things ferment, then usually at some point everything explodes. And usually that's not pretty. So stay ahead of the constipation as much as possible. And if it takes enemas, so be it. And every patient usually learns a few tricks, but we have them work with our therapist and our nutritionist to discuss dietary changes, strategies, and timing, and exercise still. Exercise is still going to be very crucial for anything in your life and on your symptoms. Well, as I said, unfortunately, often the incontinence is due to overflow. Sometimes it's because you have taken at that point too many laxatives, or another times again is the issue of the bacterial overgrowth. Now, also, again, because you have MSA, you're not immune to have things that everyone else has. So a little bit of pelvic floor dysfunction and laxity is common in everyone getting old, particularly women, or particularly people that are overweight. So that means that the problem will compound. So be careful about that. How about the diarrhea? Well, again, the key is try most of the time in your situation is to stay ahead of avoiding a lot of accumulation of stools for many days. And the other thing is careful about abusing laxatives. There are medications. Some are easy to use and some are very problematic. For instance, medication like amitriptyline, yes, will reduce the diarrhea but cause a lot of other anticholinergic symptoms, dry eyes, dry mouth, bladder retention, worsening orthostatic hypotension. So that's very tricky. Clonidine will worsen the blood pressure problem. So really becomes a big challenge to manage it. So as much as possible, we try to use things that we can work with dietary adjustment. Caffeine is a big offender. Did we serve coffee this morning, by the way? And again, medication that are not absorbed but act only at the gut level, such as loperamide. And again, careful with the sugars. Sugars can cause osmotic diarrhea, okay? So for those of you that have a sweet tooth, anyway. So some of you may present also early in their career to a gastroenterologist. Now, some gastroenterologists are very much in tune with this and some are not. Really, it's a subspecialty in gastroenterology, motility, and it's a big one. And we have some folks that really were diagnosed by our gastroenterologist. So we give them a lot of credit. Okay, so let me move to the bladder now. So we already talked about the different system. If you remember the image of the multiple level from here to here to here to here. Same thing for the bladder. The bladder normally does two things. One, stores, and then when it reaches a certain volume, empties it, right? So the things that need to happen is have a normal capacity, respond to change in pressure, sense when it's full and time to go, and then do so fully, possibly without causing disasters. How often does a normal person go to the bathroom? Well, depends how many fluids really you drink, and some it's habit. We joke in the medical field, the nurses, physician, we usually joke about a bladder nurse. I mean, the nurse of a bladder of a okay, nurse's bladder. Okay, I got it. Okay. Because you say, oh, yes, I really should go, but wait, I want to finish this patient first, right? So by the time you go to the bathroom, your bladder is reaching your chin. That's bad, because if you overstretch the bladder, you then lose the sensation. You destroy the receptors. So we try to educate people to go more regularly. However, there are neurological conditions in which the sensation of fullness is lost, and the muscle then loses the power also to contract, or other times the muscle reacts too quickly. And some of you may experience the urge. Some of you may experience that I have no idea when I have to go. Some of you may want to go and can't, or they go and, gee, I thought I had to pee a lot and I just put out just a little amount, okay? So those are the various combinations, and of course there is the lovely incontinence. So as I was discussing yesterday with the patient when we did the cases for the physician, always have a urodynamic study done, because patients like you are complex. Again, you guys, as I said, are the Cadillac of neurodegenerative disorder from our standpoint. And it's not that you have just urgency or just one thing or the other. Often you have a combination. So the management is more complicated, and if not kept into consideration, you can make more harm than good giving some medications, okay? Thing that you may see is the detrusor sphincter dyssynergia. We talked before about the fact that the pelvic floor and the muscle need to work together. Say, hey, I'm pushing now, so you better open, okay? If that doesn't work well, then you have a dyssynergia, and then where you can have intermittent difficulty with leaking or inability to empty fully. And this could be due to a variety of things. It can be due to also people that had a lot of infection or trauma, whatever. But in your case, it's really an issue of loss of control. So these are the classic cases that we say, usually you lose both the upper and the lower motor neuron control. So again, the studies is mandatory before we decide to start people on medications. And this detrusor hyperactivity and difficulty with contractile function, which seems like an oxymoron. So one side reacts too quickly, but on the other, then the power of the contraction is not effective enough. And it's very common, again, in Parkinson's syndrome and multiple system atrophy. So, well, let me skip that. So, obviously, you may have just a little leak, or you may have a big leak. And you have to understand what can precipitate those situations. Generally, small leaks can be due to two things. One, you have a full bladder, you're not sensing it, you're not going, so there is a little bit of overflow incontinence. or you thought you empty it, but there is still some urine left, and then that dribbles afterward. The big leaks generally is because you either lost sensation completely, or the bladder totally lost any control and decides to empty on its own without any warning, and there you go. So again, the bladder does two things, storage and empties, right? There are various conditions why storage could be altered. One of the common things could be weakness of the outlet. That's not really a major problem generally in patients like you. That could be more an issue of, let's say, women that had a lot of children, so weakness of the pelvic floor. And then keep in mind, again, there are certain dietary things that can make the bladder function more problematic. Alcohol and caffeine, I know, stinks, but and that's an example of what may happen. So normally, if you feel that you have to go, normal person can hold it, at least to some extent. And basically, the muscle pressure rise, but the control is maintained. When you have urgency and then incontinence, you have this control, then this was to let go. And that's where the accident happens. So it's like a stuttering sort of profile, if that can make sense to you. So again, we generally classify the disorders as failure to store and failure to empty. And you may have a combination, and most of you might experience combination symptoms. Again, this is not unique necessarily to multiple system atrophy, but because some of you are women and may have had children, and some of you are older than others, you may have a problem with a prostate, or may have had surgery for prostate, or have other events in the past, things can become even more complicated. But basically, what we needed to deal with is a combination of guaranteeing that you can store enough and be able to empty when it's the right time without too much trouble. So how do we do that? Well, the first thing is work with a fluid and a bladder schedule. So this is when I drink, and after that, this is when I have to go to the bathroom. Even if I don't think I have to go, or I don't think I really need it, I go anyway. So try to stay on a schedule. If there is any chance to do any pelvic floor retraining, we work on that. So again, that we do the dual goal, both for bladder and bowel. Then there are obviously absorbent garment and things like that. And then there are medications. Now, a lot of these medications, though, are going to be a little problematic because they may, if they can control the urgency, they may worsen the ability to empty the bladder fully. They will weaken the contraction. So then you may have retention. So that's really not good. And some of these medications will worsen constipation and will worsen the blood pressure problem. So we're really, really always striving on this in a big balancing act. Again, overactive bladder, coffee, alcohol, unfortunately, are going to be your enemies. So careful about that. As I said, also the issue of empty fully is not just a neurologic problem per se. There could be other situations such as prostate problem, age related, etc. So yes, having one condition does not really guarantee you have no other problem. And we need to keep all of those conditions in mind when we treat. At the end of the day, what probably works the best when the situation is really rough is intermittent catheterization. In the past, they used to put suprapubic catheter, but they have sort of steered away from that because of infection and other issue in the management. So If there is a lot of issue with the sphincter dysfunction, sometimes using Botox can work, but I've not seen that works very well, frankly, in patients like you. The goal remains at the end of the day to prevent accident as much as possible, prevent infection. If you have urinary retention, it's an infection waiting to happen, and allow you to have a reasonable quality of life. One option was also in the past to say, okay, if the bladder doesn't work anymore and you have problem with incontinence, do a diversion and connect it straight, bypass the bladder and go to the gut. There are a lot of metabolic problems related to that, and we'll try to avoid that if at all possible. And I'm going to stop here.